Welcome to a presentation on calcium channel blockers. Calcium is involved with many physiological processes in the body, including contraction of skeletal muscle and smooth muscle, and cardiac impulse generation in the cardiovascular system. It enters the cell through calcium channels in the membranes of cells to exert its effects. There are different types of calcium channels, which are specific to different types of tissues. The channel specific to smooth muscle is the L channel. These can be selectively targeted by antagonists, which bind to a site on the receptor of the channel, preventing them from opening and inhibiting calcium from entering the cell. Blocking of the L channels causes relaxation of smooth muscle and consequent arterial dilation, which causes a drop in systemic blood pressure and reduces afterload. There is not much venous effect. Calcium channel blockers and beta blockers have identical effects on the heart. That is why they both reduce force of contraction, slow heart rate, and suppress conduction through the AV node. Here's a picture of the calcium channel blocker mechanisms of action. Here is a picture of the mechanism of action of calcium channel blockers. Basically, a calcium channel blocker prevents the release of calcium from the L channels, where it's stored, into the cytosol of the cell. The heart muscle and other smooth muscles are not able to respond then. There are two classifications of calcium channel blockers. The dihydropyridines act predominantly on calcium channels of the arteries to cause vasodilation. There's no effect on heart rate or inotropy. There may be some reflex tachycardia related to the baroreceptor's response to vasodilation. Baroreceptor reflex activation of sympathetic nerves and lack of direct negative cardiac effects can make dihydropyridines a less desirable choice for stable angina than diltiazem, verapamil, or beta blockers. Other calcium antagonists, or non-dihydropyridines, also block entry of calcium into the cells at the SA and AV nodes, reducing the ventricular response, thus making them suitable for the treatment of angina and some types of arrhythmias such as atrial fibrillation, supraventricular tachycardia, and paroxysmal supraventricular tachycardia. Because of the rate reduction, they are also more suitable for treating angina. The non-dihydropyridines also decrease cardiac contractility and are less potent vasodilators. Because each of the classes are selective, they have different indications. Dihydropyridines are used for hypertension and Raynaud's disease. The non-dihydropyridines are used to control stable and unstable angina and dysrhythmias, especially dysrhythmias arising from the SA and AV nodes. Calcium channel blockers do have several side effects as listed here. I see a lot of peripheral edema with resultant weight gain as well as headache. I have them take the calcium channel blocker at night to reduce fatigue, which is a side effect. They also cause constipation, as it must affect the smooth muscle in the bowel also. I've never seen the eczematous rash. Non-dihydropyridines must be used in caution with any type of heart block or bradycardia, as it will worsen these. In addition, heart failure caused by systolic dysfunction should not be given calcium channel blockers. Calcium channel blockers have multiple drug interactions, including grapefruit juice. They act as both substrates and inhibitors of the CYP3A4 enzyme system, affecting many drugs. The ones that are listed here are just a select few. Calcium channel blockers, especially non-dihydropyridines, should not be administered to patients being treated with a beta blocker because beta blockers also depress cardiac electrical and mechanical activity, and therefore the addition of a calcium channel blocker augments the effect of the beta blockers. When I prescribe for hypertension, I do not use calcium channel blockers unless I have no other choice because of these multiple drug interactions, in addition to the relatively common side effects.
Okay, so the key clinical considerations. The use of non-dihydropyridines with digoxin increases the risk of digoxin toxicity. Use of non-dihydropyridines with beta blockers may increase the risk of bradycardia, heart blocks, and heart failure. Cimetidine prolongs calcium channel blocker actions. Non-dihydropyridines are contraindicated in patients with sick sinus syndrome, heart blocks, and heart failure. Monitor the cardiac system, blood pressure, pulse, response, and dysrhythmias. Avoid hazardous activities until stabilized on this type of drug due to dizziness. Do not eat grapefruit. The inhibition in the CYP450 enzyme system is highly variable with individuals taking these drugs.
Thank you for your time and attention.